I'm sharing my screen, okay? Screen is visible, right, Joe?
Yes, it is, sir.
Good evening, all. Give us a couple of minutes. We are entering people into Zoom as well as YouTube. Give us a couple of minutes. Good evening, one and all. So happy to see familiar faces again. If you do not mind, please switch on your videos so that the speaker can see you. Speaker can talk to you. That will be a big favor you can do to the speaker if you can switch on the video. If you can, okay? No compulsion here. If you can. Dr. Hemraj, thank you so much. Once again, big thanks to all those people who are already logged in right on time. We are starting immediately. Just give us a minute more just to stabilize the Zoom as well as the YouTube platforms. And all those who can come in video, please do so. That will be the biggest favor you can do to the speaker of the day, so that he feels like he is talking to human beings and not computer. All right, so welcome to yet another free webinar from online dentistry. Online dentistry, a firm dedicated to continuing dental education, with its motto as redefine dental education. And last 1 year, we have been so active in online platform, redefining the whole concept of dental education. Joe, are you there? Am I audible? Is it okay?
Yes, sir. It's all good, sir.
Right. So, redefining dental education. The way we teach, the way we put across a topic is so different that next day in your clinical practice, you will get something to apply. And when it comes to final year dental students and interns, next day you will get some point to answer your final year exam or your MDS entrance exam. That's the kind of uh, modulation we have done to our programs. Established way back in 2008. Way back in 2008, online dentistry was established. Many are still surprised to know about it, but we started in 2008 with the name online dentistry and with the website onlinedentistry.in in 2008. Many people think that we just started during the lockdown last year. That's not true. We started 2008, but it was all offline programs. But our firm name was kept as online dentistry. Now we have conducted almost 122 offline courses and more than 412 online courses. Total strength of our website registration number has crossed 15,000. Thanks to the support shown by the complete dental fraternity all around the world, helping us grow. Thank you very much. Myself, Dr. Binu Abraham, orthodontist, practicing in Kochi, and I am like a speaker for ISPPD for so many years now. And my main subject of interest is orthodontics, but I also talk about photography in dentistry, and I also talk about sleep dentistry, sleep apnea in dentistry. I also talk about wine and its varieties. That's my passion again, on wine tasting. And Dr. Jobby Peter, one of the founders of online dentistry, pediatric dentist, one of the finest pediatric dentists you can meet. So approachable. Any issues you have, 6-year-old, 7-year-old, 8-year-old, 5-year-old, 3-year-old, so approachable. Dr. Jobby Peter, pediatric dentist, head of the department, Malabar Dental College, Kerala. And he is my consultant pediatric dentist for the last, 13 years or so. In my clinic, every week he's there, one full day, treating only pediatric cases. We have almost 10 centers across India at this point of time. And all the offline courses are presently suspended due to the pandemic. We wanted to restart it at the earliest, but things are going bad again, especially in Kerala. Things are going bad again. We haven't started the offline programs yet, but just wait. The moment things get better, we will start. We will announce this pretty soon about the offline courses coming out. Presently, we have webinars. We have 1 hour free webinar. That's what you are attending at this point of time. 1 hour free webinar. We also have paid webinars, which are paid programs obviously, and it's like 3 to 5 to 7 hours. We say 5 hours, but it goes to 7 hours. That's also happening. Many programs coming up. Be in our WhatsApp group. All those who are listening to me at this point of time, if you're not in any of our WhatsApp group, please be in one of the WhatsApp group so that you get all the updates. Even those people who are listening to this through YouTube, please understand, be in our WhatsApp group. Programs coming up. Caries Management. This is part 2 today by Dr. Joby. It's a free webinar, but we have a huge thing coming up next Sunday. One full day on Caries Management. Believe it or not, it has revolutionized. It has changed the life of so many dentists all around the world in the program we conducted 2 months before. The testimonial has proved it. So please look into it. If you're free next Sunday, register for this one full day program coming up. We have a full day program coming up on sectional orthodontics, 2x4. Or if you have a severely rotated central incisor or a huge diastema on a 7-year-old, 8-year-old, you want to just give a finger spring or razor spring or put a couple of brackets and close it, guaranteed results. Please attend this program on sectional orthodontics, but my feeling is it's almost full. Maybe Dr. Joe, are you here online? Are you here now? How many
Yes.
seats do we have? If I remember correctly, we have hardly 5 or 6 till yesterday evening. We have
You're right.
restricted the seats, right? Am I right, Joe, on that?
Yes, sir. Yes, you are, sir.
We have really restricted seats to strict 30 people because there's live bracketing, live wire placement, but all related to young age, 2x4, 7-year, 8-year, 9-year, 10-year, not full-fledged orthodontics. We are not going to the complete orthodontic mechanics. We are only looking into 2x4s. And then Dr. George Paul Sir, one of the finest oral surgeons in the world, who is a lawyer by himself in profession also, other than oral surgeon. Sir is talking about unconscious patients in dental chair. What happens? God forbid, hope it doesn't happen. But if a patient is unconscious in your chair, what will you do? Do not miss Sir's program. All the protocols you have to follow. He's even planning to talk about what happens if the patient is dead in the dental chair. What are you supposed to do? It can happen, guys. It can happen to anybody practicing dentistry. What can he do? What can a dentist do? What should a dentist do? Whom should you report first? To the police? To the local people? To the patient? To the bystander? Patient is gone. To the bystander? He's going to cover all that protocols, what you're supposed to do when it comes to an unconscious patient in a dental chair. Do not miss that if you are a practitioner. Professor Venugopal sir is showing something on his screen. I can't see that, sir. What does that mean? Can you just explain that? You want to explain that? I can unmute you for a second if you want. We are running short of time, but since you're showing something so much, I thought I should ask.
Sorry, I'm sorry.
Now, what is it regarding?
Actually, I was checking my video, the settings. I thought.
Okay.
Sorry,
Sorry.
I'm extremely
fine. That's fine. So then we have stuff coming up on panoramic radiograph. You all take OPGs. How many knows exactly how to look at an OPG? What all to look at an OPG? From where to start looking? Tomorrow in our WhatsApp groups, I'm planning to post a case that came to me 2 days before. 2 days before a case came to me, I'm planning to post that tomorrow on OPG and the importance of CBCT. I'll post that tomorrow. It's my promise. Technical team listening to me, please remind me tomorrow. I'm going to post on that case which came as an OPG, and then the CBCT gave an entirely different diagnosis altogether. So importance of panoramic radiograph and CBCT, or everything coming up. And then mini implants, orthodontic mini implants. Now you will think orthodontic mini implants is for orthodontists. No, I'm going to cover about the importance of orthodontic mini implants and so many other things in general dentistry, including individual adult molar intrusions. Molar intrusions, how many times have you seen a supra-erupted molar? So that you can't put a proper implant down there because the molar is supra-erupted. You want to get that molar up, or you'll have to do an intentional root canal and chop it off. Instead, intrude it using mini implants, orthodontic mini implants, and its general dental uses will be covered by me in that program coming up. Then, orthognathic surgery. Everything you have to know about orthognathic surgery will be covered by none other than Dr. Sherry Peter, one of the finest Orland maxillofacial surgeon. Dr. Sherry is going to talk about, as a general dentist, what you should know to talk to the parents whether this is going towards surgery or not. Why are you hesitant? Why are you worried about telling on face, okay, this is going into a severe class 3, this might go into a surgery. Why are you worried? What is your inhibition? And Dr. Sherry Peter is going to cover all that. That's about the orthognathic surgery. And then look at the next one, orthopedic movement. If you had done that right retraction of the maxilla, of the mandible at the right age, it wouldn't have gone into surgery. So do not miss the program coming up on orthopedic movements. Hypo headgears, protraction face mask, chin cups, all that with the biomechanics completely covered coming up soon. And then mouth breathing symposium coming up very soon. It's already done. We have a moderator, we have a symposium coming up, everything on mouth breathing alone. It is your moral responsibility to explain to your patient that the patient is a mouth breather. Doctor, please take the teeth back. But it is your responsibility to explain to them the importance of mouth breathing and the importance of the cause of that proclined teeth. Why is the teeth proclined? Why is the maxilla narrow? Why is the teeth out? It is your responsibility to make them understand that. So that is the mouth breathing symposium coming up. Then very interesting topic coming up, local anesthesia. Oh my God, I'm giving injections every day in my practice. What are these fellows going to talk about local anesthesia? Right from the schedule H, right from the adrenaline, the concentration, the non-adrenaline, the plain ones, everything covered. How to actually take the thing out, the sterilization part, the infection control part, cross-contamination part, and then how to give the correct inferior alveolar or whatever. Even for a third year BDS to senior most practitioner. That's what we are planning. Third year BDS to senior most practitioner should get benefited from that program. That's our plan about local anesthesia. Guys, with that, I just want to give one more small announcement that we got connected to Lincoln University, Faculty of Dentistry, Lincoln University, Malaysia. And we are now tied up with them. So many of the programs coming up, you are going to be getting certificate of participation from Lincoln University, Malaysia. Watch out for those programs also. Those who are still not our members, please note these numbers 98470 or 94463 Please personal message and be in the WhatsApp group so that you get all the updates about the beautiful programs coming up, which are absolutely free. Understand that. For the dental fraternity, struggling for 1 year with the pandemic, and now with the rise in the cases, we are looking forward to yet another lockdown. God bless. Thank you very much, one and all, for coming in. Over to Dr. Jobby, the speaker of the day, pediatric dentist. Only a pediatric dentist can talk real sense about caries because they see caries from the age of 1.5 years. 1.5 years they see caries. Maybe 10 months they see caries. So there is nobody better than a pediatric dentist to talk about caries. Over to you, Dr. Jobby.
Yes, Binu. Thank you. Thank you, Dr. Binu. Am I audible? Joe, am I audible? Yeah, fine. Thank you. Thank you so much. Yeah. Venugopal sir, Nayan, Dr. Farhin, thank you so much. Senior most people are there. I hope everyone is safe and sound. My prayers for everyone in all over the world, especially in India. Let us hope, let us cross our fingers, and let's hope we will overcome this pandemic wave 2 as we have done in wave 1, and we'll soon back to our practice as early as possible. And we online industry, as an academic head, we have planned for lots of free webinars which are all clinically oriented, because many states are undergoing lockdown and dentists are again back to their home and they don't know what to do. So we have planned lots of clinically oriented free webinars are going to come up in this couple of months. That's the introduction Dr. Binu gave. Let me go to my topic of today, which is a part of the sequence which we are doing it. It's called dental caries. Oh, Dr. Joby, what are you going to talk about dental caries? I do every day. I do fillings every day. I do excellent composites. I do excellent glass ionomers, which are the latest gadgets I have. And even adults, I do inlay, onlay, whatever. Then what to talk about dental caries? This session, especially on tonight, is very important because it can change your practice a lot, because I'm going to talk about the recent concepts and things, and especially prevention, which is the grassroots level in management of the dental caries. So we had one session in a week back, tremendous response. This was the exact session which I repeated in for South African Society of Dentists, and the response was humongous. Thanks for all that, for your support. So today I will be repeating a second session of this, followed by next Sunday a comprehensive session, so that no more theories on the next Sunday. It's going to be more practical and clinical application part on next Sunday there. So just to revise those people who are not today, just a quick 5 minutes revision. Yes, last Sunday I talked about web of causation, which is the cause for any disease, be it be a dental caries, be it be a cardiac disease, be it be a diabetes, be it be any hormonal imbalance. There is a web of causation in your body that causes, and then only we call it as a disease. So that is a factor. So even dental caries also comes under a disease. It is not just a cavity that you see, that I discussed there. So you talk about coronary disease. Last time I talked about it. It's a acute or a sudden symptom that has happened and patient is rushed to hospital. The only thing that a doctor can do is either open heart surgery or angioplasty or angiogram, whatever, depending upon the situation the doctor can do. So what the doctor is doing here is a surgical management of a disease which is present in him. The disease that is present in him is what he has treated there. Exactly Tomorrow morning, a patient or a pediatric patient comes in front of you with a severe pain, and parent says that patient or patient says that yesterday night I did not sleep, my kid did not sleep. That's an acute condition, like a heart attack that has happened, is happening in the patient. That's happening for this patient here. So here again, whatever protocols that you are doing now is a surgical management of caries. That's it. You deal with that tooth, fill it, shut it, forget it. That's all done. But if the patient had little more awareness or knowledge, education, or social circumstances, or he was guided by somebody and he was regular checkup and everything has been done, he would have reduced the risk of getting that acute attack, or he has reduced the intensity of that. That is called medical model of management, controlling it. That maybe a family run patient who has got a family run cardiac problem or cardiac issue, or high cholesterol, it's a hereditary factor, it's there. You can't prevent it, it will happen unless they control it, monitor it, and do that. That's called medical model of management, controlling and monitoring it at regular interval. That is being done. Now, dental caries, once it was recognized as a disease, there are models called medical model of management of dental caries has come. JADA 1994, it has come. From since then, it is revolutionized the concept and management of dental caries. Be it be a pediatric patient, be it be an adult patient, any patient, the disease called dental caries has to be dealt in a different way. You have to consider it is a disease purpose. That's called medical management of dental caries has come into existence there. So you all know the ultimate result of a dental caries lesion is cavity gone, tooth is totally destructed, and it is irreparable. So one is the medical model of management of caries is the one that can prevent this, the last resort, that inevitable thing that is going to happen can be prevented with the medical model of management dental caries. But to get this idea, you need to understand the caries is not just the cavity. It's not the depth or cavity or the size of the lesion is important to us. We should understand that it is a disease. It's a dynamic disease. Diabetes is a dynamic disease, not a static disease. Thyroid disease is a dynamic, it changes. So many disease changes. It's a dynamic disease according to the patient's lifestyle. So many factors, it changes, it's modulate. It keeps the patient at more risk. It keeps the patient at lesser risk or moderate risk. Now, our question is to find out the patient is at what risk it is. And because it's a disease, is a dynamic, at any time it can go into peak level, at any time it can submissive, it can be very submissive and arrested kind of thing, but suddenly it can blow up like this. Let me tell you, I treat a lot of interceptive orthodontic patients there, patients which do not have any caries initially when I started. Suddenly, at the end of the treatment, I can see shooting up with caries. I will show you one of the cases which I had never expected. Shoot at, like every tooth have caries lesion appearing there, which start of the treatment was not there. So what was the reason? So that is why I said it's a dynamic disease it is. So you should know that. And the mode of treatment keeps on changing. 15 years, what materials and modes that you're using is changed now, and we need to update that. And finally, whatever material you do, whatever material you patch it onto the tooth, mind you, the manufacturer is not giving you any guarantee. The distributor is not giving any guarantee. The salesman is not giving you any, doctor, it is very good, that's all they say. But you need a sound tooth structure for any material to be placed. Be it be a Ivoclar, be it be a 3M, those Henry Saint, any company material view, do not fall for that. Be dentist, look to the tooth structure. Do you have a tooth structure to fill? Do you have a sound enamel? Believe me, enamel is the key. Do you have that? You are good. Any material will work. If the tooth structure is not there, no matter whatever you do, it's better to pull it out and tell the patient, sorry, it's not going to stay there. And patient factor. Another factor which I discussed is about the patient factor, which will be again covered here. It's an important thing that we have to consider in that. So finally, we have to diagnose this as a dental caries as a disease. To diagnose this as a disease, we have newer classification systems are there. Now, we all are thorough with our GV Black's classification, so many other classification systems we are there. But to understand it as a disease, GV Black classification will tell you a tooth has got a cavity and it is this, that's all. It doesn't talk about the other factors there. Here, the system tells you a tooth first, then it also tells you holistic way of identifying every tooth is taken into consideration. You don't need a cavity to form dental caries. Even without cavity, dental caries disease is starting. You don't need a heart attack to get coronary heart disease. Even before that, you have risk to get that coronary heart disease. Exactly same way, you have that factors, risk factors is with you, or the patient have the risk factors, eventually will develop dental caries, which can be a cavity or without cavity. Totally distracted root stem, but a factor will lead ultimately into that. So this system of classification will help you to identify each tooth and clubs together and say that, oh my God, this patient is definitely having a problem in the future. You can get, I also gave you the website address. You can go download the system and you can read more about that. Just brushing 2 minutes, just brushing what I've discussed, that they have classified into 6 courses and I discuss each course very in detail. A sound enamel, which is course 0, then comes an enamel with a drying. You can see a whitish appearance, like after etching, you get a chalky white appearance, that is called code 1 in an enamel. After drying the tooth, you get code 1 whitish appearance on the fissures. You can see it's called code 1. Now some patients comes and when you open up, even without even drying, you can see white patches then and there, then and there. You can see, especially in pediatric patients also, you can see that's a little more severe condition for code 2. You can see then you can see a localized enamel breakdown, because just enamel is broken out, minute breaking down of the enamel has happened, and that's called code 3. And code 4, with or without enamel breakdown, you can see halo in the dentine and enamel. You can see a halo surrounding a lesion. You can see it is maybe with breakdown of the enamel or without breakdown of the enamel, little more severe lesion. Code 4, you can see with or without breakdown. Even in the restoration surrounding, you can see halo. That's called code 4. And code 5, open lesion. You can see enamel is completely lost, dentine is visible, and you can see cavitation in opaque or discolored. It can be like opaque or discolored depending upon the stains that dentine has absorbed, but it's an open lesion, but it is involved enamel and dentine there. And lastly, it is a wide extensive lesion which has involved at least half of the tooth structure. Half of the tooth structure is already involved, or more than half of the tooth structure is already involved. That means it's a last step. So these are the things that we discussed there. So guys, let us have a case discussion here. So that will be the best way to go ahead with the management of that. A 14-year-old patient is walking for a regular dental checkup. Patient they want to do an orthodontic treatment. So she's just walking in for a regular orthodontic checkup. She's 14 years of age. This is her upper arch and this is her lower arch. She says that she has some discolored teeth. That's not a problem. So look at this upper arch and look at this lower arch of a 14-year-old patient. What will you do for this patient? Their chief complaint is not for orthodontic mainly, but the stains are there and they also want orthodontic treatment. Sometimes they come to, there are some stains are there, and teeth are coming out. Parents on add on to the chief complaint, they may say the main problem is when they open the mouth, they can see the two teeth discolored. That's the main problem. And then they add on to that, they say that the teeth are coming out, can we do something on that? That is also, that is secondary. The main problem is that teeth are discolored. When they can see black discoloration there. What will you do for this case? With it? There are no pain, there is nothing, no problem. How will you approach this? So I'm just directly going into how will we manage this case in our clinical situation. Is there is the one thing that I'm going to. So this next slide which I'm going to put is a very important slide, which exactly what I do in my clinic when I see a patient who says that I have a cavity, be a big cavity, be a smaller cavity. I have severe pain, acute pain, be a big or small, but it takes not less than 2 to 3 minutes to say. The amount of time you take to see, exact same amount of time only it will take with experience. As you do it multiple times, you will able to do within 2 to 3 minutes, you will be able to come to this diagnosis. So whatever the condition, the patient said, I have a cavity, I have a discoloration, I have food impaction, whatever patient says that, the patient exactly like this is sitting in front of you, we will do, let us see how we can go in our clinical practice there. The first thing that I'll tell you is, first, see the caries is visible when it is wet. That means with the saliva, with the caries is visible. Absolutely big lesions are always visible even without drying. But that is what, see all the teeth with the saliva inside the patient mouth. Do not dry, do not do anything. Just ask the patient to open the mouth. Just see the upper arch and the lower arch and see whether the caries is visible when is with the saliva is there or not. Okay, fine. You identified that. Now there are two options there. In a tooth, there are two options. Either it can be no dental caries I can find. No, nothing. Or it can be yes, there are dental caries which are there. Fine, good. Now you found out some tooth has got dental caries. Which tooth you identified that. Now for this tooth, what you can ask, there can be two things for this tooth. What is one thing? Cavity. There is a cavity. That's why even without a wet or anything, there is a cavity. You can say very big visible cavity or a mild cavity, or moderate, whatever type of cavity you can say. Now ask yourself, is the cavity with exposed dentine? The cavity is open up and the dentine is exposed or not? You can get two questions for that. Either no or yes. Imagine it is yes. Yes, the cavity is huge, wide open, and you can see it. Yes, cavities with exposed dentine. I can see it. Yes, it is. So what can we do that? Next question to be asked is very important in a clinical examination, is that the size of the lesion. Next question is very important. What is the size of the lesion? Is it involving half the tooth or more than half or less than half? Very relevant question. Is the size of the lesion is involving more than half or half of the lesion or less than half? So that is a very tricky question there. More than half or less than half. So there can be two options here. Yes, it is involving more than half. Almost entire tooth is involving, or 2/3 of the tooth is involving. You can have that. Or you can say, no, it is not involving more than half. It is not less than half of the tooth structure. So if it is involving more than half of the tooth structure, half and more than half the tooth structure, ICD's code 6 come into play. ICD's code 6, it's gone. It's pulpily involved. It's gone. You have to have a drastic methodology. It's an acute condition there. No, it is not involved more than that. It usually comes into code number 5. Again, IOPA. These two conditions might require your IOPA and their classification. And there's no time to explain that. We will be discussing all these things in our one-day program. So this is code 5. No, it is not involving, but it comes under code 5. It's a deep kind of lesion there. Now imagine cavity with exposed dentine, but you cannot see the exposed dentine there. Cavity is exposed, but no dentine is seen. No, I can't see a dentine there. Look at this Look at this clinical case. I can't see a dentine there. There's a small opening is there, but dentine is not exposed here. Some condition you can't even see this exposure, just see a halo. There might be a filling and a halo. You can't see a dentine there. The thing is, can you see a dentine here? No, I can't see a dentine here. I can see a small export, but halo I can see. Yes. The next question is, there is undermining shallow is present. Undermining shallow is present or not? Surrounding the lesion, there is a shallow is present or not? Shadow is present or not? Yes, it is present. It is code 4. It's called code 4. With or without dentinal exposure, a shadow is present and which is visible. It is called code 4. No, there are no shadow, nothing. Then what to do? I can see that, but there is no shadow is there. What you need to do is air dry it again. Just air dry it again and observe it again with a visual examination. Completely dry it and see is there is a micro cavitation with your visible eyes. Any micro cavitation is there with your visible eyes is present. Yes, there is a micro cavitation is there. Mild micro cavitation is there. Then it comes your next code, code 3. Microcavitation, but dentin is not exposed. Microcavitation is there. That is code 3. No microcavitation. There is no. I dried it and there is no microcavitation is there. Then is the lesion is pertaining into the fissures. Only in the fissures it is pertaining. There is no opening up, no cavitation, but only in the fissures that discoloration or that kind of cavity is present or not. Yes, it is only on the base of the fissures. It's code 1. That is code 1. No, it is code 2. It is code 2. No, it is not only onto the base, but it is bigger, deeper. Here you can see only onto the base you can see, but here it is more deeper. That is code 2. Lesion is not pertaining only onto the base of the fissure. It is code 2. It is only onto the fissure. It is code 1. Now comes the next part. So this is about a caries visible when we wet. Now comes a caries which is visible, not visible. When I wet the lesion, it is not visible. What should I do for this? So we are going to specific thing. A caries lesion, when it is wet, I can see, we discussed about it. Now we are discussing about a caries, visible caries lesion. When it's, I can't see the lesion when I wet. What should I do? Dry it again. Dry it and reevaluate again. If any opacity is there on drying, if there is an opacity is on drying. So in that patient, I started without drying it. I saw that lesions, all those procedure I had done, I marked the point and codes for each tooth. In the same patient, some lesions I can't see now when it's dry. So I dried it. Then I looked at it. Oh my God, I can see the opacity now, which was not present in this wet. So any opacity or discoloration that is present when after drying it, yes, it is present. It is code 1 again. And if it is no, it is code 0. That means sound tooth. Now, why we should know this system of classification in depth? This determines your treatment protocol. So easy. You identify each tooth at the same time. You identify holistically that patient is having a huge problem. See, it's like a coronary heart disease. You have only one heart. So all you need to do is the heart and the surrounding blood vessels that is come to it. That's it. But we have 32 teeth. So we need to identify each tooth has got a risk or is under risk or it's already affected or not. This system will give you each tooth is affected, under the process of getting affected, or at risk of getting affected. clearly tell you. Now it's so easy for you to apply protocols of your preventive thing. Now what happens is, so many times we get a picture with full blown mouth caries. They send me the picture and say, sir, after filling, sir, can I ask remineralization? After this one, can I ask fluoride? So many questions we get. The reason for this is they have not understood what is happening inside the mouth of the patient. They have not analyzed each tooth, surface of the tooth, and what holistically happening inside that, and then start apply. You do your conventional filling. I'm not telling you do not do. You do your conventional filling, composites, best material, you do that. But they have to stay there, right? How they will stay? You need a sound enamel. Dentine is not at all a good place to keep your restoration. Enamel is the best place to keep your restoration. So you need to identify, because all caries process start with stages. It doesn't happen all of a sudden. It starts with a sound good enamel just erupted into the oral cavity or being there in the oral cavity, and then suddenly start getting code 1, which is demineralization at the base of the pits and the fissures, and it spreads into stage 2, stage 3, stage 4, stage 5, and stage 6, and finally go for extraction. So this will give you which stage each tooth is there, and let me concentrate on that and that and that, and holistically let me manage. Then you will get a better result there. So before starting that, you need to understand the patient, why that is happening. I told you, in a patient who never had, after the appliance, the patient start developing such a huge amount of caries, or sometimes we can see patient comes with a already huge amount of caries, but they are not bothered. So different, each patient each patient you have to evaluate that. And the scoring system which we have told you is very important. And one other important thing is caries risk, which I will discuss at the end of this. The most important indicator, you don't need any other test. One most indicator to tell you that patient is having a high caries risk, we'll be discussing at the end of this webinar. So today's session, I will be managing holistic methods to prevention of dental caries, remineralization of initial caries lesion, fluoride, sealants, and PRR, enamel biopsy. Let's again start with one case. This is a 8-year-old patient came to me with a complaint. Patient is saying that, sir, sorry for that. Patient is saying that all her cousins, all her classmates, neighbor who is 7.5 or 8 years of age had 4 teeth came out. My son is almost 7 to 7.5 years of age, but his 4 teeth has not come. Front 4 teeth has not come. Can we remove that 4 lateral incisors? The 2 lateral incisors which are anyway shaking, started shaking. So can we remove that? His teeth has not come. So this mother is not even worried what is happening inside. She is worried about the milk teeth, which is going, permanent teeth, which is going to come. Her son doesn't have permanent teeth, but others, neighbors or cousins or aunties, sons has got 4 teeth. My son doesn't have 4 teeth. So can you remove that 4 teeth, that lateral incisor? That is her only botheration. She's not even worried about the primary teeth which are mutilated. She's not even worried about even the permanent molar is erupted and that has got caries. Now, into this mother, you can't expect a 6-year-old, 7-year-old, 8-year-old child to do everything well. Into this mother, how will you approach? No matter whatever you tell and explain, this mother is say, I'm not worried, sir. That's a milk teeth, no, sir. It's going to fall out. So why should I do that? What can we do? When shall we remove this? That is their worry. So the parents or the patient's attitude is very important. I had a very tough time to convince this parent. This is a 48-year-old patient. who was my constant treatment patient, but no, never came up for our prescribed appointments. She suddenly came in this corona time with very tensed and shivering. Corona is there. If I come, I will get or not. But what I saw, doctor, when I woke up in the morning yesterday, I saw a swelling in next to my premolar. This premolar, next to the premolar, there was a swelling. Abscess was there. She was worried about that, and I read and learned more about this can be cancer, this swelling, according to the lump and swelling is a cancerous thing, so that's why she rushed and came. Even the corona, she's not ready to listen to any other thing. Only thing is she want to know that lump is cancerous, that lump will go by itself, is it problem, should I do anything, that's it. Now, to this patient, can we talk about this ICD's classification of individual teeth and its management? It's, they are not bothered. You cannot, you should not do that also. So patient related factors are very important in selecting a case in your clinical practice there. Like, are they aware? Are the parents, or if the young kid, are the parents aware about it? Is they still think about some milk teeth is going to shut off, or new teeth is going to come and they'll be perfect, paka, no problem? What can you do that? So their awareness and motivation is important. Or adult patient, they know that if one teeth goes, I have another teeth. What will happen? I can use other teeth. There I have 32 teeth. So if one teeth goes, nothing's going to happen. Other teeth will take care of its function, and they're not bothered. They don't have value for that. And hygiene. Some patients are say, I brush, I do everything, I'm very aware. But when you see inside the mouth, what they do, what they talk and what they do is entirely different there. The diet of the patient, and tooth related problem, accessibility to health in rural areas they have thing, and financial status. So many things are there. This is not a time to talk about all, but clinically relevant things I'll be discussing. How can you make your patient aware in your clinic? Forget about you are not working. See, in my appointment, minimum 20 to 30 minutes, I talk, show to the patient with the laptop, with pad, everything. We sit and talk to the patient. But there is something which can be tremendous things that you can motivate your patient. Your reception itself can be a motivator, booster, doubt building dilemma to the patients. Put the notice board with caries, and because that's the most common thing here, that's the most common thing is the caries one. Put some pictures before and after, aggressive and thing. Let's patient sees that, and put in a colloquial language and put it onto the screen. And your TV screen should not be showing Pogo channel, should not be showing any Discovery channel or anything that can see in the house. Show your own cases which you have done before and after, or some videos, motivational videos about dental caries, and it's a very common thing, that can be done. Even the mother might see that, okay, I suffered, let my son and daughter doesn't suffer, but or my friend doesn't, they can give reference to you. And intraoral cameras, an amazing tool. Must, we are having a planning to have a 1 hour 45 to 1 hour session on intraoral camera for our next Sunday. Amazing tool. Invest on the 3,000 to 4,000 rupees. Within 2 patients you will earn that. Invest a good intraoral camera that talks a lot, that shows the all parts of the mouth, and that's an amazing thing that you can put onto that. And even sometimes we even show our iPad and or the tablets, we show them the videos on the chair, the aggressive kind of things, the worst kind of things. Show the pictures of young children who had and adults who had, before and after. That talks a lots and lots. That makes the patient aware. Okay, fine, I came to the right place. It can happen to me at one point of time. So these are the ways that you can motivate the patient, make the patient aware about it. I even give links, because nowadays all are technique. So I give them, I will WhatsApp you the link. You just go and see it and watch it. That's all converts the patient, makes the patient aware, and they come back to you. Another thing visible that can do on your chair is use of a plaque disclosing solution or a plaque disclosing tablets. That's also works wonders for adults or any patients. You just use this and ask them to see the mirror. They might be see this surprised to see. And nowadays you have something called dual plaque disclosing solutions are there, or tablets are there. Older and newer plaque can be distinguished. The light blue are older and the pink one are newer plaque. So that means the patient is not properly brushing on the gingival areas. He's brushing his horizontal scrub method, so he's not brushing on the gingival area for many days. So those things can be done. And in my Facebook or in my latest in dentistry, we have a huge group called latest in dentistry. I get so many posts saying that before and after picture done, either with full denture or full with implant supported denture. They post so many pictures. I like this. I do not criticize anyone. Nice work, nice lab work, everything is good. But why did this patient have this much number of decayed tooth or condition? Have you thought about it? Now, is that implants which you have put are going to stay inside? Is peri-implantated? Is it a danger? Because his habit is not going to change. Oral hygiene is an important thing. It's a habit. It is like thumb sucking, mouth breathing, tongue thrust. It's a habit. Daily morning getting up and doing correctly is a habit. If he doesn't have that habit, is very busy or whatever, you can't do meticulous treatment onto him. If you want to read more about it, two authors, Rinsey and Hodges, have clearly mentioned that oral hygiene plays a very important, and they gave a recommendation. And their recommendations, whatever gimmicks you do with materials, with implants, with the full mouth rehabilitation you do, if that thing has to be stuck on the tooth or inside the mouth, the evidence that brushing per se is important in the prevention and control of caries in the current population there. So you can't avoid oral hygiene of the patient. You should have to assess that first before doing any broad procedures or full mouth rehabilitation inside the mouth. I do full mouth rehabilitation of general anesthesia or conscious sedation, total mouth rehabilitation for 1.5-year-old, 2.5, 7.5, every patient I do. But after doing, I tell the mother that there is no guarantee unless you follow my protocol. And with God grace, even they are in Gulf, in UK, in Canada, at least in a month, due to this corona, but at least to WhatsApp, they are following it up. That is very important. Doctor, what should I do? What should be the next protocol to be done? That is very, very important. Oral hygiene is very, very important. So to maintain oral hygiene, what you have? Brushes you have. So I want to ask all those people in Zoom and YouTube who are there. There are so many brushes to purchase from the market. Which is the best brush to indicate your patient? So many time patient comes and asks, doctor, which is the best brush? Is there any, should I change my brush? Which brush am I using it? What brush will you indicate to your patient? What prescription will you write in your prescription pad so that the lab or the pharmacy know, okay, this is what you said. Can anybody come into the chat and tell me what is the ideal prescription for a toothbrush to a patient who is asking you, doctor, which is the best brush should I use? I'm waiting. Can I get an answer? What's the best toothbrush I should prescribe? Okay, fine. Everybody's confused. Or maybe, okay, I got an answer. Sorry. Somebody answered it. Soft brush, angulated brush, okay, ADA specified soft brush, fine, good, doctor, nothing wrong what you said. Now, I am going to post two pictures. This is one and this is one. Which toothbrush, the left side or right side will you prescribe? Right side or left side brush, which one will you okay, right side, and some Smriti says that left side, Gayatri says the right side, fine. Right side, right side. Okay, all of you say right side. That means this one, this guy. Fine. You know, there's a study done. So many authors did a tremendous study, and this is a recommendation they said. I will quote the author's name here. Use a small headed brush which is soft, round ended filaments, a compact angled arrangement of long and short filaments and comfortable to handle. This should be the recommendation given by a doctor to a dentist, because each person's dexterity don't know. So never ever ask the patient to say this right side one. No, this is not good. But that short and long length of the filament are the best. Second thing is always prescribe soft. There is ultra soft and there is medium, but always for general population, common people, if you're prescribing it, it's a soft one. And this is a tremendous study by Sharma et al. Has done, and said the clinical effect of plaque and gingivitis over 3 months use of 4 complex design and manual toothbrushing. So if you're prescribing a manual toothbrush, it should be short and long with angulated one is the best, rather than your uniform type of filament that is present there. And angles are better because it removes, because each tooth position varies there. But our patient will have all the angles and all the filaments are angulated because they use a brush for this period of time. 3 years, 2 years, they will use the same brush, and they have get all the short angle or the long filaments in one single brush, just to set a job. So now we are coming into the treatment recommendations there. So patient factors we have done. Now coming to each tooth factors. So there is something called treatment tooth related factors. What is, if the patient is sitting in front of you, I identified the patient, I have code 1 in some teeth. What protocol will I do? I diagnosed in that patient is having a dental caries as a disease, and a tooth has got code 1. That means that when I dry it, I can see a whitish appearance of the enamel, either labial, lingual, proximal, occlusal, whichever area. When I dry, I can see a whitish chalky appearance there. When I do not dry, I can't see it. So that is code 1. What shall I do in this situation? So each tooth specific we have come. So what should we do? Either the permanent or the primary. So I already told you about the patient matter, that is you have to take care. But the most important thing for this kind of lesions, I discussed about the subsurface caries mineralization last lecture. When you have this kind of situation, the must thing is remineralization techniques are the one that you have to follow. What is remineralization technique? The whitish patch that has happened is due to demineralization. So you have to remineralize it. Whatever things that is lost from the enamel has to be replaced with that. How can you do this remineralization? Should I do something? Nothing you need to do. You prescribe the patient these two pastes which are available from GC, and so many other companies are there, are GC mouse and MI paste. MI paste contain fluoride, and GC mouse is the only calcium proteins are there. SCP, CCP are there. That is a calcium casein phosphopeptide proteins are there, which are contain calcium and phosphate. So they will go and bind onto the demineralized area and causes remineralization and saturate the saliva also. So MI paste, which contain 900 ppm of fluoride, is also there, which they have not exposed which type of fluoride it is. It's a patented fluoride that is present inside that. So it causes faster remineralization, which is indicated for high risk patients. So I'll be coming at the end how to sell the patient is high risk or not. So for a moderate to low risk patient, you can recommend GC tooth mouse. For a patient high risk patient, you can recommend MI paste, which has got fluoride incorporated into that. So how apply this? It's a very simple procedure. Take this GC mouse in your finger according to the age, pea size, smear size, or whatever size. For adult, it is like a pea size or more. You take, apply onto the labial, lingual, palatal, all the aspects, and just ask the patient to hold it and swish it, just the saliva itself. Pull the saliva around the tooth and just swish, keep on swishing it for 1 to 2 minutes and expectorate maximum. Do not brush or put water onto that. That is about remineralization protocol with GC mouse or the MI paste there. Now, another tooth, one of the tooth I identified that there is a distinct visual changes even without drying. That means one teeth, when I dried, I could say, oh my God, whitish lesion is there. Next tooth, without drying, I can see that there is a distinct visual changes is there. That is code 2 that is there. So what we need to do, you need to arrest it. You need to further demineralization should not happen. Now you know that whitish patch is due to demineralization. So you need to prevent that. You have to arrest the lesion. So how can I arrest the lesion in this? Preventive dentistry is the best for that. And here comes the role of fluoridation, fluoride, professionally applied fluoride in the form of gel, varnish, or foam that can be applied. And one company which can I use is gel company, which is a very good 60-second application, is all you require, no 4 minutes, 60-second application can be done. But if you keep it for 4 minutes, it is good. So for adults or little cooperative patient, I keep it for 4 minutes. But young pediatric patients which are very difficult to manage, I keep it only for 60 seconds, but that also delivers a good effect for that. Gel from Pascal company. It's an acidulated phosphofluoride there. They have a foam also available. It's also different color. It's a very soothing for young children. You can use APF foam is also there. Then comes fluoride varnish. One company which is commonly uses food protector from Iocla, where it comes in 1 ml ampule and it has to be stored in refrigerator. You take it from the refrigerator, you open it up, you apply for the entire mouth and discard it. So that's food protector. The thing is, food protector has got only 0.1% of fluoride, which is around 1450 ppm of fluoride. But the advantage is it has got calcium in that component, and it causes faster penetration and taking up of enamel by the fluoride by the enamel. That is why it is again recommended. But let me tell you, this is usually we do it for mild to moderate cases because of the fluoride content is not very vast. So mild to moderate case, this is a very good product that you can use. Now they have come up with another product called Food Protector S, which contains 1.5% ammonium fluoride, which is around 7,700 ppm of fluoride is present there. It's a very good product that also can be, so moderate to high risk, you can apply that. Or the best, what I use very commonly is Voco, 5% sodium fluoride, which is kind of 22,600 ppm of fluoride. It's an amazing product. It comes in different flavors. You can use that. So no restriction on any product which is high caries risk, more the fluoride varnish. Any fluoride like Durafet, there are so many other varnishes are there. You can use that, which contain high amount of fluoride for high risk patient. You can. So what is high risk? I will be discussing at the end of this last slide. I will be doing it. So the technique for application is just a paint on technique, just like how you apply your dentine varnishes. You apply with a cotton roll isolation. You apply all the two surface. If interproximal area, take it in a your dental floss, put it on the interproximal area so that that area also is being covered there. So paint on technique can be done there. That's amazing use of fluoride varnish. A must tool in your clinic is because it can prevent caries. High to moderate risk caries can be easily prevented. Even patients who has got xerostomia, dry mouth, this can reduce the caries risk and sensitivity also. Yes, and differently able patient who cannot maintain the oral hygiene, and patients who undergo neck and surgery, neck and radiation, neck and head radiation, which can cause osteoradionecrosis, which can be prevented if you use fluoride before and after radiation therapy there. Very poor oral hygiene patients is very good there. And hypersensitivity. So sodium fluoride is being tried and successfully reduces the hypersensitivity in kids, and root caries in adult geriatric patients it reduces. And even there are studies which says that you apply fluoride after your crown preparation in a non-vital tooth, apply fluoride and then dry it for 2 to 3 minutes, and then you apply a temporary, and next time you give a permanent filling, that enamel or the dentine become more little more harder and stronger, and less chance of fracture of the tooth structure with the application of fluoride varnish is there. And geriatric patients, this is an amazing tool to prevent dental hypersensitivity or root dental caries there. One clinical tip I want to tell you with application of fluoride is, if you are giving multiple porcelain or ceramic or zirconium crowns, if you are giving, or if you are doing composite restorations, please do not use APF. You have to use neutral sodium fluoride. You cannot apply APF gel or foam or APF varnish. You have to use neutral 2% sodium fluoride, because it is neutral, so no pH is there. Otherwise, it can cause etching of the composite, etching of the enamel because of the pH level there. So what is the neutral sodium fluoride? You have again, Sultan has got Topex 60-second application of fluoride foam and gel, and Dendicare by Medicom is also available, which is again 2% sodium fluoride, neutral sodium fluoride. So these are one precaution that you should see before applying any fluoride on any patients, either composite or you're like zirconia crown, pediatric zirconia crown, Figaro crown. You give lots of crowns. So in those patients, make sure you do not apply fluoride varnish or gel with APF. High acidulated content should not be applied there. Now, the reason for applying fluoride is your subsurface demineralization. You know that this is the reason that you want to remineralize it. So that demineralization goes off. Whatever mineral is lost can be replaced back. So the underneath there is cavity, or cavity is getting formed, or deeper lesions are forming, but surface is again intact. That is our main aim. So the most important thing in the application of remineralization technology or fluoride, either gel, varnish or foam, is white spot lesions. That is one lesion. So this comes under code 1 and even up to code 2. You can use your fluoride and remineralization technology effectively before it becomes a cavitation. So code 1 and code 2. Even in code 0, some condition where patients are under high risk because of the habits or medication suddenly changed, we substitute with remineralization protocol, or we substitute with fluoride therapy, so that we know that the situation has changed and he can get caries there. So these are the conditions where you apply fluorides or this one. Now, in condition where localized enamel has broken down, that is code 3, enamel has broken down, but no visible dentine or dentinal shadow is present. Just the enamel has broken down. At some areas, minute speckle of dentine, enamel has broken down, and okay, that is code 3. Here comes the role of sealants. This lesion appear as discolored lesion because of long-standing nature. So there comes the lesions of the importance of sealants as a preventive measure, or enamel biopsy, we call it, or PRR, we call it. So Pitt and Fisher sealants are recommended in these conditions where enamel breakdown has occurred at some point. It is not only restricting only onto the base of the fissures, it is slightly more extending onto the base of the fissures, or some area slight enamel breakdown has already happened. Pitt and Fisher works wonders there. Discolored, susceptible pits and fissures with high caries or moderate caries risk, Pitt and Fisher sealers can be done. So what are the materials available for the Clean Pro? The 3M Clean Pro is there, which is a good material that can be used there. Then comes Heliosil F, but that contains fluoride by Ivoclar, is another material that you can say. And the latest one is Embrace Wet Bone. So you don't need any proper isolation also in those cases also, because saliva helps, or moisture helps in in curing or better bone strength. So you have Embrace Wet Bone is also there. So the method of application of a sealant, you have to dry or clean the tooth with your cleaning brush, micromotor with the cleaning brush. If the patient is not cooperative, I use a patient's own brush. I ask the patient to clean that particular tooth. Once it is clean, your cotton roll isolation is more than enough, and apply the etchant. So once you apply the etchant, many people just apply the etchant and leave it, but I suggest you spread the etchant to the maximum area of the tooth surface, so that it get maximum retention in there. So apply it and spread the agent. So you get a frosty white appearance like this, you get there, and then you apply the sealant. Just spread the sealant like this. Once you spread the lens, once you apply the sealant, you spread the sealant all over the tooth surface and then go for light cure, and so that you can see the entire tooth surface have got a minute layers of the sealant. So the whatever etched area is being covered by the sealant, and the main bulk of the sealant remains there, and it stays there even 12-year long. The patient we have seen where sealants are still remaining on the tooth, because this protocol is very important there. And also, once you have cured and done, you have to check for your high points in the sealants there. So this is a case before sealant application and after sealant application on the tooth surface. You can see there's a self-cleansing area there. Now comes sometimes when you see some areas, you can see a catch or a cavity or a darker or a catch or a proper enamel involvement is there, which is needs some cleaning, it should be there, but rest of the fissures are intact. In those area wherever the caries lesion is involved, in those area you can clean it meticulously with a round burr or whatever burr you find, small burr you can find, and clean that particular area. Rest of the area is only stained, or only the fissure or the caries lesion is only on the base of the fissure. So why you want to extend that? You don't need to extend, you can remineralize that, you can allow them to heal back. So that procedure is called preventive resin restoration. Those areas where there is a cavity or a little bit enamel disintegration is there, you clean that area a little bit around, you remove it, you fill a biomimetic material there, and then what you do, you remove an entire tooth is filled with a pit and fissure sealant. On top of that, a pit and fissure sealant is applied and cured it. So this is called enamel biopsy. That means you did a biopsy of that area, removed all that, and rest of the lesion is filled, or the enamel is filled with a resin material there. So example, a case, a palatal pit, you can see it is caries there, prepared the cavity, and that is filled with a biomimetic material, but the entire tooth, the other fissures are also susceptible, are filled with a your pit and fissure sealant material. It has been done. So the choice of the materials to be used also plays a very important role in remineralization, because your conventional GIC is one of the material that you can choose, because it has got fluoride releasing there, and it has comes with the resin modified, but you cannot use resin modified GIC in all lesions. There are specific indication for resin modified GIC and conventional GIC. So, and then comes after that compomers are come, which has got a combination of a composite and a GIC with fluoride releasing, which again causes remineralization. And there are so many other materials that has come. So we'll be discussing in detail on the next Sunday program about all these materials, its indication, it uses in detail on that. But remineralization is possible with the smart materials called GIC, and its combination is available there. So early management of dental caries lesion is the one that I discussed. You have to understand or detect the lesion, that the signs and symptoms. You finding out the signs and symptoms is very important, because you know that the white spot or the chalky white appearance eventually will become a cavitation. So you need to prevent it as early as possible. So you have to focus on the individual tooth, see each aspect side of the site of the tooth, and entire mouth you have to rule out that. So this is a patient. I can just do those fillings which has need required filling. The 3 teeth filling, it is done. I will be, according to the patients, I have done justice to the patient. But according as a doctor, dentist, understanding this is a disease, I should say that caries risk is the risk portion, because other tooth which are doesn't have a visible cavity are under high risk, because they are whitish in appearance even without drying. Even without drying, they are whitish in appearance. So I know that they are under high risk. They will develop, eventually become caries. Do I have to wait for that to become caries and fill or not? And there are other sites which are intact tooth so far, okay, which are only while drying hard, you can say visible point. They are also under high risk of developing caries. So should I wait to become more whitish, or should I become a cavitation? That's called caries risk assessment of the patient has to be done. So the management of the dental caries is not just filling. before and after filling, you put in Facebook, put in, that is not dental caries management. It is caries risk assessment is very important. Finding out, and one of the most important thing is past caries experience of the patient. Look into the patient mouth, how many missing teeth are there due to dental caries. Look into the patient mouth, how many root stems are there. Look into the patient mouth, how many cavitated, failed, or currently present cavitated lesions are there. That gives you a good clear-cut clinical application saying that this patient is high risk. You don't need a salivary dip test. You don't need any enamel susceptibility test. You don't need any test, but past caries experience is the most acceptable and authenticated way to say that this patient is a high risk patient. So evaluate that. And we have a 3 to 4 minutes clinical form to assess caries evaluation, which we'll be discussing in the class in detail. 3 to 4 minutes, you can tell this patient is under high risk authenticated. By past caries experience might tell you, but still patient may have other diseases, other things, and oral hygiene, sort of things are also there. So that will give you a clear cut, definitive diagnosis saying that, okay, this patient is high risk, and this is internationally accepted form that we are using and we'll be discussing. So finally, what is the dilemma? Yes, Dr. Jovi, I listened to your lecture. I found out, okay, cases which you showed. I said, what is the dilemma? The dilemma is, when should I start? What should I start first? How should I start first? First dilemma is openly fit and fissure sealant. When should I use it? Which tooth should I use it? Which condition? Tell me the indication of fit and fissure sealant. Let me tell you, pit and fissure sealant should be used in those susceptible pit and fissure. Now, what is susceptible? Deep pit and fissure. Sometimes you might even see there are no stains, nothing, but you can see a lot of deeper pits and fissures. Just seal it. You will be doing justice to that. You never know patient habit changes there. You are not doing you are not drilling anything, right? Just drying it and putting a ceramic sealant, just making it self-cleansable. At any point of time, patient can get dental caries. So if you find a susceptible tooth which has got deep furrows and fissures, seal it, that is better. If you see a patient who doesn't have any caries lesion, drying it also you would not see, but patient oral hygiene is bad. You can see a lot of plaque on the buccal side. Oral hygiene is bad, gingival bleeding. That's what the form I told you, that form clearly tell you, or he's undergoing a medication or he's undergoing any process. Seal it. Do not take the risk. Seal it. You will be doing justice there. That is the indication of pit and fissure sealant in a clinical perspective point of view. Just seal it, so make it self-cleansing so that it doesn't causes dental caries there. The dilemma 2 is what to do in case of non-cavitated enamel lesion. Many people ask this question, sir, it is non-cavitated enamel lesion, what should I do? So like this lesion, multiple lesion, I can see white spot, multiple area, what should I do? In primary, permanent, what should I do? Remineralization technology with fluoride and gizimos is the god, is the new thing that has come. So in those conditions, you need fluoride varnish and remineralization substituted with that. So daily protection, you can't apply daily fluoride. So you need remineralization technology on daily purpose like GC toothmost, and plus depending upon each patient's age and all those things you should do. So in non-cavitated enamelation, the best thing is either fluoride or GC toothmost. And let me tell you, even we use fluoride, your pit and fissure sealants also we do that. You seal that and then start apply fluoride and remineralizer. So a lot of combination also is being done. So only 2 dilemma I have discussed. There are so many other dilemmas like non-cavitated lesion, but dentine is involved. Cavitated lesion, enamel cavitated, dentine is involved. So many other protocols are there where we conserve the tooth maximum, and the materials which I've told you are amazing materials which can give you better results. So conservation of the cavity, selection of the material, assessing the patient risk, and making all in a composite way is called caries management, which is an elaborate topic. You need to read more about it, and definitely you will come up and you will get a lot of knowledge. In the World War II, a group of army people were walking on the fighting on the World War II. They were carrying the donkey with the supply. You know, this donkey used to carry all the supply, basic supply they need on their back. So the soldiers were carrying the donkey on his back, and the soldiers were walking because they realized one thing, that if they leave this donkey free with a thread, he will walk there and there and there and there. And in a war field, everywhere there is mines. So the donkey go and touch the mine, it's explode. The soldier is gone, the donkey is gone, both are gone. And the most important thing is the reserve. What is the reserve? The donkey is carrying. That is also gone. So what these people do is they carry donkey on their back so that donkey does not wander around and self-immolate with the mines. Save the donkey to save the reserve. So my point is, save the tooth structure to save your restoration, your filling and longevity of the tooth. Save the tooth structure. So thank you so much. Thank you so much for this. I have taken 10 minutes extra. Thank you so much there. And you can catch us in all our social platform media, online dentistry, all the social platform media, you can catch us. And thank you so much for your patient listening. And if you have any doubts, I'm open to the chat in YouTube. And it went, Dr. Binu is there. Dr. Binu, are you there? Any more questions? And hope to see you all on next Sunday. It's an elaborate 7 to 8 hour session on caries management. Entire procedure will be discussed in detail. There are no theory, all practical, short videos and case discussions will be done there.
Dr. Joby, can I take a couple of questions?
Yes, Bill.
Sir, after Pitten Fisher sealant is given, patient keeps complaining of high points, and finally after reducing sealants, almost get removed. Any tips?
Yes, doctor. The reason for this is, once you do a Pitten Fisher sealant and you are not supposed to touch it. If you need to reduce it, that means your procedure of application is wrong. So there, what you need to do is the thing that I told you many times. I told you that many times people put the Pitten Fisher sealants onto the grooves, and immediately they just do some little brushing, and then after that they immediately go for seal. So a bulk material is being kept onto the fissures. That's not the right way to do it. You have to put the sealant, spread the sealant maximum onto the tooth surface, and then light cure it. You will never get any high points. And do not put. Some people use flowable composite as a Pitten Fisher sealant. That's another mistake. Many people does that. So please check your material that you're using, methodology that you're using. Usually, after a proper sealing, you should not get high points. If you get a high points, you're supposed to remove entire sealant and redo it. That is the recommendation from ADA.
Sir, can you suggest a good intraoral camera? That is something which I should answer. I am detailing on that topic next Sunday. But to answer it in a very simple way, I would say it's not exactly the cost that matters. It is the user friendliness. I mean, a patient is there in front of you. You should immediately get it out and show it. You can't get multiple things connected at that time, and that will take off the interest in you as well as the patient. So big screen, showing it in big screen and showing it quickly is what matters. We'll be covering that next Sunday in detail.
Dr. Binu, somebody's asked the previous lecture session. I think it's a YouTube link.
It's already there in the share. Sir, when can we decide if drilling is necessary before giving sealants?
Before giving sealant, doctor, if you are if you are drilling, then it is a therapeutic sealant technology. It's a therapeutic sealant. It is not a preventive sealant. What I've talked here is all preventive sealant. Drilling is if you're drilling, then it is a therapeutic sealant. You have to assess the tooth and the tooth structure and the condition, and the material and the methodology of choice also different. You might have to do a enamel bonding agent, and a lot of other things will change. So that depends. All cases may not require that. As I told you, if you feel that the fissures require a little more widening, if you feel that is a, you go for your preventive therapeutic sealant. Nothing wrong in that, but that depends upon each case where you find the fissures are deep and stained and food debris are coming out. So better to open it up and clean it, do a enameloplasty. But then it comes up therapeutic sealant, and you might be able to, might require to use a enamel bonding agent, your single bond agent or something. You might have to use it to do that filling for, I mean, to finish that procedure. Otherwise, you will never use a bonding agent because in whatever says in the preventive sealant methodology, we never use that.
Dr. Mittal Satra in YouTube has asked, we shouldn't do full mouth APF if patient has multiple fillings, question mark.
APF, yes.
Do full mouth APF if patient has multiple fillings.
If you have, if you have multiple fillings of composites or multiple of zirconia, whichever porcelain or ceramic, whichever etchant, whichever acid can etch. If it is there, you should not be using APF. You should be using neutral sodium fluoride, 2% or 5% neutral sodium fluoride varnish or gel is the best.
So best toothpaste for hypersensitivity.
Oh, that depends upon each condition, doctor. Your Sensodyne, which has got triclosan, without that, and so many Inafex, which I use it again. Inafex is there. So many other Promin, another company are there for specifically for sensitive. Find out the sensitivity is due to the reasons like abrasion or attrition or erosion. If it is due to dental caries, you may not find this the best option there.
Your view on silver diamond for SDF. Your view on SDF.
Yeah, SDF is an amazing tool. SDF again, it is not a remineralization protocol here. SDF works better when the dentine is exposed, and if you apply that, it literally arrests the dentin lesion. So it's a little more advanced lesion where the cavity preparation is reduced. You don't need to prepare a huge kind of cavity in an open lesion also. So which will be discussed, as I told you, next Sunday, which will be discussed in detail about the silver impregnated filling restorative smart technique, where it's an amazing, especially for a pediatric patient, it's an amazing thing. But that doesn't cause the stops the remineralization process, okay, altogether, because that particular lesion, it stops, it arrests and it stops. But another side and site of the tooth, it is at a risk. So again, our protocol of preventive dentistry comes handy, but as a newer methodology, this will arrest enamel or dentinal caries, especially dentinal caries, tremendously. And after that, you can go for your conventional filling on top of that at a GIC, resin modified, compomer, ornomer, whatever material you can use on top of that, and you can get a better result because tooth structure, the base, the sound tooth structure become stronger and harder.
Sir, how can we, Dr. Fatima, how can we differentiate between ICDS Core 4 with enamel breakdown and Code 5?
Code 4 is enamel breakdown with or without enamel breakdown, but there is a halo of the dentin, hidden caries. The best to tell you ICDS 4 is hidden caries. With or without enamel breakdown, there is a halo, blackish halo. Sometimes you might have seen around a amalgam restoration which is completely sealed and well, but surrounding you can see a halo. That is secondary dentinal caries is there, but it is not exposed. So that is ICDS 4. 5 is open lesion. Enamel is involved, dentin is involved, but less than half the tooth structure. Less than half the tooth structure is involved. So it is a deep lesion, but still pulp is not reached, or you have to take an IOP and decide that. 6 is definitely almost purpose involved with that lesion. So there is a radiographic classification of ICDs is also there. You have to compensate, you have to correlate that to take a final treatment protocol.
Dr. Rajalashmi in YouTube has asked, where do we use non-fluoridated toothpaste?
Dr. Rajarashmi, very rarely we recommend to use non-fluoridated toothpaste, especially if you find a patient who is coming from a fluoridated area where water supplies has got a fluoridation is there. Family history is the mother, father, not much caries in child also. You don't find any kind, and risk facilities like child is not too much prone to sweet, and having regularly maintaining the oral hygiene, you can say. But studies which I've quoted, the many studies, there are two studies I have told that, which they said that by time every person changes their habits. A 6-year-old child may not have the same habit at 12-year-old, may not have the same environment at 12 years of age. So as you asked me the question, for that particular point of time, the patient is under your control and everything is monitored and not at risk, non-fluoridated toothpaste is good enough. But as I said, this is a vast topic to discuss in patients, which is usually in the current situation. You can always recommend fluoridated toothpaste in mild form. Fluoridated toothpaste starts from 250 ppm, 550 ppm, 900 ppm, 1000 ppm, and like that it goes on. So 250 ppm fluoridated and non-fluoridated doesn't have any difference at all. So even in case of any mild amount of attack happens, mild amount of fluoride exposure would be better than a no. But if the patient is allergic or any kind of allergic reaction, or patient is from a high fluoridated area, like a water supply has got a high fluoride, or food habit like a coastal areas, or where fluorosis is very imminent, then you will never recommend this fluoridated toothpaste to these patients there. Non-fluoridated toothpaste will be better for these patients.
Sir, when should we do tunnel preparation, Dr. Unnati in Zoom?
Tunnel preparation is done, is an MID procedure, minimal intervensive dentistry procedure, where if you see either in a premolar or if you see in a molar, where below the cervical contact area there is a caries lesion is there, but the marginal ridge is intact and healthy there. So you will be able to see a halo kind of things on the occlusal area, but the marginal ridge is intact and sound because of the remineralization, because exposure to the fluoride, those areas are very intact. But underneath the contact area, there is a deep caries lesion is there. So rather than conventionally, like Dr. G.V. Black said, you break it the marginal ridge, make it a big cavity, fill the material. That is not the concept now. What you do is, because we have so many biomimetic materials like ormoses, geomers, all those material, biomimetic material which has got fluoride release, calcium phosphate fluoride, three things they will release. Those kind of materials have come, and there are materials which regulate themselves according to the pH. That means if the patient's pH drop down, this cement will produce excess calcium and phosphate, so that they will neutralize the saliva. So those kind of materials also we'll be discussing next Sunday. Those materials are there. So these materials are, since they have come, what the latest concept is, preserve the marginal ridge, just directly go from the occlusal side, a small burr, use it, approach it, remove the caries, and now you have caries detecting solutions are there, like cariesol is there, caries removing solution, detecting solutions are there. And this solution, when you use it, you can remove the infected dentine and leave the affected dentine back, and you keep this biomimetic material. They will cause remineralization of the dentine and seal the lesion there.
One last question in Zoom from Dr. Fatima, that is, sir, is electric toothbrush better at plaque removal?
Yes. Oh, this is the question that that I told you. I just covered the. There are around 8 questions a dentist can ask or tell to the patients. 2 questions I covered: which toothpaste should I remove, and oral hygiene. And third question, what you asked is electric versus manual toothbrushing, which is the best. And now, this is a very controversial study. There are studies which says that electric brush is better. There's other studies say manual toothbrush is better. No, there is nothing like that. All the toothbrush are good. It is not the toothbrush that is important. How the patient use is important. Now, that comes an important thing. There are some patients whose manual dexterity, they're very busy. A child is little, very, hyperactive and not bothered about all those things. You cannot tame all those things. So in those kind of selected patients, electric toothbrush is better because it is very easy to clean and goes and cleans an area. And certain kids are techno savvy. They like, okay, electric, I'm using electric toothbrush, so I am an upper hand, or it cleans better. Those kind of things they have. So they like those electronic gadgets more. You apply electric toothpaste, that is better. Otherwise, if you see, both does the same function, unless if you the method of toothbrushing is there. So if you are prescribing electric toothbrush, you have to have a oscillating electric toothbrush, not the regular rotation. Circular motion toothbrush is not good. Oscillating type of electric toothbrush is the most recommended electric toothbrush.
All right. I think we are done, Jobby.
Yeah,
Excellent job. A topic which no webinar has ever covered. I've never
exactly.
seen a webinar talking about such basics. I think people like to talk about big stuff, but you have talked about pure basics. Tomorrow morning, first thing in the morning, they are going to see this. They are going to apply it. That is the importance of this topic. Thank you very much, Dr. Jobby. Thank you very much, all the participants who are here. And please do not miss this chance next Sunday, full day program, complete demonstrations, video demos on how to do sealants, how to do fillings, all that coming up next Sunday. Do not miss that, and lot more programs coming up. Be in the group. If anybody listening to us still not in our WhatsApp group, send a personal message to one of us, 98470 or 94463212220. That's it. Dr. Jobby, can
Yeah.
we call today? Thank you very
Yes.
much.
Thank you very much. Good night
Bye.
to all. Stay
See you all.
safe. Take care.
Stay safe, guys. Stay safe. See you all next Sunday. Thank you very much.